Good morning. My name is Dr. Anand Shukla, Professor at UNMICR Institute of Cardiology. Our today's topic is relevant angiography. As we are doing the angiography lot, but how we can do the impactful angiography. So today's discussion on from the basic and how can we do the meaningful angiography. So we know that today's scenario, the coronary angiography has been done to diagnose a suspected case of ischemic heart disease, ACS, PAMI, pre-surgicals, and many other pre-transplant, many other indications. So number of indications has been extensively increased in today's scenario because of not only the indication pertaining to the ischemic heart disease evaluation, but it is also involved the other system, as I mentioned, the pre-liver transplant, pre-renal transplants, all are the indication for the coronary evaluation. So whether we apply the same protocol to each and every patient or we can modify and make the angiography impactful. So today's focus on this. So science means what we follow the evidence-based practice in protocolized manner, and art means when case-based minor deviation from the standard practice to add the meaningful value. So this being the DM cardiology, we require some sort of minor modification in each and every indication to have the safe, meaningful angiography. Every institute have their checklist protocol for the angiography. Majority are the standard protocol because we take the history to determine the indication of the angiography. Among the history, allergy is most important, allergy to any drugs, because patient might develop minor to the major anaphylactic reaction because we may give the antibiotic as a protocol or the local NHS allergy, contrast allergy. So we have to take into account. Also, we have to take the history of the patient on the anticoagulant, thrombolytic, received thrombolytic, antiplatelet, and when patient receive all this blood thinners agent. PTINR, patient who are on the anticoagulant, and anti-factor 10A assay if available. Majority center though not available, but anti-factor 10A if patient on the NOAC for any reason. CBC for the hemoglobin and the platelet count, because lower the hemoglobin carries the higher risk for the angiography. Importance of previous coronary angiography report or previous revascular detail, particularly PTC or CABG, should be reviewed because it will give the meaningful information prior to the diagnostic procedure. Any investigation, ECG, echo test should be evaluated because in test the high risk variable, one should cautious about expecting the left main TVD picture. So the angiography to be quick and meaningful for the revascularization purpose. Among the examination, one should evaluate all the peripheral artery route because of both radial, femoral, because majority of angio has been done for the radial. If previous angiography has been done to radial route, the 10 to 15% of patient, the radial will be the absent. So the evaluation of the peripheral artery from which the angiography to be done. In case of post-CABG, if details are not available, then chest X-ray can give the thoracic clip, means the lemma has been harvested, and clinical examination patient will give some clue, indirect clue. Suppose there is a radial scar or bilateral saphenous lower limb scar, suggest patient have received the saphenous or the radial venous conduit as a bypass conduit. And also the thoracic clip, right and left. Right thoracic clip suggests the lemma has been taken. Rarely gastroepiploic artery. Whenever the subxiphoid incision has been extended lower down, then think of the though the majority surgeons are not using in our country, but These are the indirect clue which graph has been used from the clinical examination. Fistula in case of CRF, we should avoid the limb from which the AV fistula has been done for CRF patient on Maitland dialysis. If angiography has been done for the pre-transplant evaluation, then we know that the transplant kidney is implanted in the right or left iliac fossa. Though if we are doing the angiography to the femoral root, we take utmost important to avoid any injury to the internal iliac, because where the anastoma, the transplant kidney has been anastomosed. So to avoid the future complication. There are certain high risk variables in the severe pulmonary hypertension, LV dysfunction, recover from the heart failure, borderline creatine or low GFR, eGFR, hemodynamic unstable patient with perioperative MRI, patient who underwent the non-cardiac surgery and develop MI, non-invasive test show the high risk ischemia burden, angio for PAMI or SES, and volume depleted. We have to take utmost care because these are the patients develop the peri-procedure complication in higher chance. So we have to remain alert, use a lower amount of contrast and get the maximum information in such kind of patient. As I previously mentioned, the contrast reaction is most important. There are protocols to desensitize the patient for the contrast, and also the recent history of the patient who are the low eGFR on the ACE inhibitor and metformin should we withdraw 2 to 3 biological half-life. Anticoagulant thrombolytic agent, if we are taken, then we should keep in mind that thrombolytic agent, suppose we are taking the patient for the rescue plasty after the failed thrombolytic. In such case, the heparin dose and all we have to adjust as per the patient anticoagulant or thrombolytic status. And patients who are in the high chance of contrast-induced nephropathy, proper oral hydration has to be done. So, what are the basic steps? Though it is look basic, but each step very important. Catheter selection, guide wire, advancement of catheter toward the aortic root over the guide wire, then aspiration of the catheter, connect with the manifold, manipulate catheter to selectively engage the coronary ostia, good pressure waveform, nitroglycerin intracoronary administration, optimally position patient to avoid the radiation hazards and image quality, pressure and the ECG quality, and the angiography. So these are the basic steps for the angiography, one by one. Catheter selection, it is most easily required because of easy engagement and safety. Catheter should be coaxial with the coronary ostia, left or right. It should provide optimal support, particularly in the plasty. Depend on the site, radial and femoral, different catheters. In radial, the Thermo, the Tiger radio focused catheter or the Kimney catheter, different catheter available. Once you are doing the angiography from the radial, the curve slightly lesser than compared to the femoral root. And the size of the aorta, suppose patient is a tall, you may require the larger curve catheter. Patient is a short, you may require the smaller catheter. So before taking patient, rather than the routinely using the same catheter in all patients, one should assess which type of catheter patient might require. In echocardiography, once we feel pre-echo that the aorta is too large, then patient may require the larger curve of the catheter. So such kind of catheter selection will help to select the coronaries better and good quality angio. Such kind of catheter, once seat has been secure, once we pass the guide wire, from femoral 035 or 038 J-tip standard wire, or in radial small baby J Thermo wire or the 035 wire. Usually we pass the wire through the seat and under fluoroscopic guidance allow the wire to reach the aortic root. Suppose we feel the resistance while passing the wire, the reason being the resistance of the wire might have, there is some forward occlusion is there in the pathway of the coronary artery, or wire might have entered in the side branch, or wire have done the dissection or the perforation, or we are in the subintimal space. So without forcing the wire to push toward the aorta, whenever someone feels the resistance, one should stop the forward pushing and assess the fluoroscopy while wire is not. Otherwise, majority time wire will reach the aorta. But if it is not reached, they require the undue pressure. We should think of the different reason for the not able to push the wire in the ascending aorta. Once the wire has been reached in the aortic root, we usually railroad over the guide wire. Wire has been reached. While railroading the catheter over the wire, you feel resistance. Then one is reason for the spasm, other is the tortuosity of the vessel, or some dissection. Wire has been passed through the subintimal space, then through space. So these are it should be confirmed by the fluoroscopy and the bleeding. So whenever you feel the resistance while pushing the catheter over the wire, we have to stop, confirm the reason and solve the problem rather than the blindly pushing the catheter. So once the catheter has been reached the ascending aorta, we remove the wire, and usually we aspirate to 2 to 3 ml of blood. So any air bubble, microparticles are there in the catheter we remove from the catheter. Otherwise, they are inadvertently injected in the coronary ostia or the systemic artery that lead to the complication, embolic complication. Once we reach the ascending aorta, not able to aspirate the blood, the reason being the catheter might be touching in the aortic wall, or there is some air entrapment, thrombus, plaque, or catheter has been kinked. So these are some common possibility. We have to rule out that possibility and then engage. So always aspirate some blood before selectively injecting the catheter. It avoid the major complication. Then we connect the catheter with the manifold with the secure manner without intervening any air trapping or the clot or anything. And once we connect the manifold, we see first we see the pressure waveform in the monitor and the ECG. ECG should be stable. We have to keep image of the baseline ECG. What is the baseline ECG when starting of the procedure? And also we look for the pressure waveform. Pressure waveform, there's normal pressure waveform being good, diacritic notch, and the pulse volume. Damping, ventriculation, that should be picked up early before injecting the dye. The reason for damping and ventricular catheter against the aortic or the coronary wall, or subselectively engage in the branch, most common in RCA, the coronal. So there is when damping and ventriculation. Significant ostial lesion. If significant, there's some spelling, ostial lesion, that also having the damping and the ventriculation. Or too large size coronary in catheter is small. Sometimes you may come across such pressure changes. And sometimes catheter contain or system contain the air and plaque or kink, that also to lead to the bad waveform. We should obtain the correct pressure waveform, then start the angiography. Then sometimes the pressure transducer malfunction also lead to such. So you may require again the zero and the obtain the good normal pressure waveform. Then once we obtain the good pressure waveform, then selectively engage by the manipulation. In femoral artery, in left coronary, if you are using the Zetkin, just forward push, it will automatically engage the left coronary. In the radial route, we are using the turbocatheter, that is a tiger. Then also we require the clockwise rotation and the counterclockwise rotation to engage the left and the right coronary ostia. If we are not able to engage the ostia properly, then there may be chances of anomalous origin, ostial occlusion, tortuosity. The pathway tortuosity in catheter not allowed to manipulate the catheter, or suboptimal catheter size. And suppose we have taken the small catheter in large aortic root, then or large catheter in small aortic root, then also. And sometimes the eye origin, we have not taken that pro. So that's why important of proper catheter selections are required to select to do the hooking. Before starting the angiography, if blood pressure, just give that small contrast test to scout, and if it is okay, then give the night. If blood pressure allow, if blood pressure less than 100, give the 50 micro nitro, 100 micro nitro in between the 100 to 120 systolic pressure on 200 micro if blood pressure more than 1, because to avoid undue coronary spasm that will overestimate the lesion. These are more common in the right coronary artery, or sometimes the female left men are so hostile to the catheter touch if underwent the spasm. So nitro will give prevent the overdiagnosis of the stenosis. Next, when we start the angiography, there should be the patient should be optimal position, because as high as possible in the table to avoid the radiation export to the operator. That is a radiation CP. Image detector should be as close as patient body. Shielding position, there are upper body shielding, lower body shielding. The upper body shielding between the patient and the operator, lower body shielding between the table and the operator foot. That will have radiation protection to operator and their assistant. Operator position as far as possible from the patient and excessive. These are the basic day-to-day ever, because radiation is the major occupation, the hazard. Majority time our institute and majority institute, they are the manual injection. But some of the institute, they are using the patient in automated injector. For the RCA, that is a 6 ml at the 3 ml per second for 450 psi, and left coronary system 10 ml at 4 ml per second, maximum 450 psi. These are the volume useful, particularly when you are doing the ACT. The automatic injection will give the good quality imaging. Usually we do the angiography in the lower frame rate, that is a single 7.5 frame per second. Next magnification is 15 and 22 frames per second. But better to do the angiography in the lower frame per second to have the whole angiography without minimum panning of the patient table. In tachycardia view or pediatric patient, sometimes may require the high frame rate to get the good quality. So whenever a patient is in the tachycardia, and if you are going to the angiography 7.5 frames per second, the image quality will not be the good. So now what are the poor angiographic possibility? Inability to fill the coronary artery. The catheter we might have taken the small or side hole, or coronary artery large ectatic, poor engagement, hypodynamic coronary circulation, weak injection, high contrast viscosity, or patient hypotonic, high LVDP. So there are the slow flow. So there are the severe endothelial dysfunction, also not able to give the good quality angiography imaging. So among the poor quality angiography, if you take the patient factor, that is a obese patient, the image will be not as good as the normal patient, because the radiation required to penetrate a large tissue mass. If patient take excessive movement during the angiography, even body movement or the rapid respiration will lead to the poor quality, hardware. Suppose patient having the previous bypass, previous multiple pacemaker wire, and so multiple prosthesis. If spinal scoliosis and the fixation has been done, that are coming in within the imaging, where metal prosthesis are there, and we come in the imaging during the angiography. Cardiomegaly, heart failure, lung filled with fluid. These are the patient-related factors for the poor angiographic appearance. Then angiographic favor the poor catheter selection. Suppose we have taken the too small catheter for the larger left main, or a small catheter for the non-selective injection, or inappropriate injection, weak injection, or a catheter with the side hole that will fail to occupy the both coronary borders simultaneously for sufficient period of time. that lead to the poor quality injection. Then equipment, X-ray generator problem, because there are many vendors for the cath lab, but high heat, quantum model, too high kV, too long or short pulse width. These are, suppose X-ray tube get heating, even in the best quality cath lab, one can appreciate the image quality of the morning edge and image quality of the late evening in high volume centers are different, because once the X-ray tube get heated, then the rapid cooling system not functioning as efficiently as it should. So that lead to the deterioration of image quality. Another is X-ray tube problem, anode pitting, wrong focal spot and poor collimation, and sometimes the digital program processor malfunction due to poor quality angio. So once the artery has been secured, usually for diagnostic we give the 50 unit of heparin, 15 unit per kg, and therapeutic at least 100 unit per kg in absence of previous anticoagulant, or in patient who are not with normal platelet. Patient on thrombocytopenia, we use bivalodin or may use the LMWA. Fluoro guidance to reach the aortic near the system, no selective small count, and the first session pressure tracing and ECG, and then start the angiography. So there are the different angiographic projection. We briefly for the left main dead AP view, cranial view for left main ostia, and LO-caudal, RO-caudal, PA-caudal for the distal left main. For proximal LAD, RO-caudal and mid LAD and distal LAD, PA cranial or RO cranial. And diagonal, PA cranial and LO cranial view will be the better. For circumflex, proximal, LO view, PA caudal view or RO caudal view. It depends, it is not the fixed, because patient anatomy and coronary origin are different in different patients. So the important part is certain view is not, you can go apply fixed, it depends on the coronary variation. In right coronary, usually we take the LO, slightly allocranial, lateral or RO view to evaluate the coronary. Rarely we take allocaudal for the proximal RC evaluation. So while doing the angiography in the iris, where previously slide I have mentioned patient with the PH, heart failure, renal, we should use the minimum contrast to get the maximum information. So once we take the one scene angiography, then we think of how many injection we require, how we can reduce the contrast amount, in particular the high risk patient. That is the most important. And coronary angiography in chronic coronary syndrome, usually the low meaning avoid panning. Lesion should be defined in two orthogonal view. Best view of the lesion assessment is where the lesion is not for certain and maximum length. And pre-test, whenever patient in high risk of ischemia, left main TVD, we should always remain on the toes to avoid any undue complication. And whenever you find the CTO, then we try to define the proximal cap of CTO, distal cap of CTO. And if you not able to define the distal segment of CTO or the viable artery, we think of we are missing the collateral. This particularly happen in the proximal LAD when cornel give the collateral to the proximal LAD. We selectively inject the dye in the proximal RCA, and there are separate origin of cornel or the RCA. So we miss the cornel injection and we miss the LAD filling. So we should think in this case of CTO, and we try to define the CTO, proximal and distal cap and collateral grading. And for if we think that during the angio we found that the patient is candidate the surgery, then we have to think from surgeon perspective. They attach the graft to the distal vasculature. So the character and quality of the distal vasculature we have to delineate properly. So they feel confidence to grafting the mid to distal LAD, distal OM or the PDA PLV. So from that perspective, we have to demonstrate in angiography. So there are minor modifications as per the CABG, as per the PTC, as per the CTO. So these are the minor modifications important to take the decision. Thank you.